We have keynote address by Dr. Nitin, Medha, Prabhudesai. She will be speaking on post-trauma secondary glaucoma. Dr. Medha, please.
Thank you, Dr. Mandal. I would like to thank you, the AIOC Organizing Committee, for giving me this opportunity. I'd be speaking on trauma-induced glaucoma current perspectives. So, by definition, it is a post-traumatic rise in intraocular pressure, which may result in the optic nerve damage. Onset can be acute or it can be chronic, which usually remains underdiagnosed. So this is a case of 15-year-old male. He had a shuttlecock injury 3 weeks back and patient complained of pain and diminution of vision. On examination, the vision was 660 and 36 in the right eye. Pressure was 42. Patient had traumatic mydriasis, sphincter tears were there, and he had corneal edema also. Even the disc was hyperemic and showed disc hemorrhage. There was zonular dialysis. There was pigment on the anterior capsule, on the cornea also. Disc hemorrhage was seen, and patient had hyphema in the inferior quadrant along with deepening of the anterior chamber, as you see here. So this was done when the pressure came from 42 to 10 millimeters of mercury. As you can see, it's a paradoxical retinal edema which is showing RNFL thickening actually. But if you see the red-free photographs, there are multiple defects over there, RNFL defects superiorly as well as inferiorly, and the perimetry revealed this. So patient had advanced visual field damage following the high pressure following secondary glaucoma. Even the OCT angio of the disc showed reduced capillary density in the right eye as compared to the left eye. So trauma-induced glaucoma can be of many things: blunt trauma, penetrating or lacerating trauma, which we see often. It can be due to chemical exposure, electromagnetic radiation, and even after surgery. So risk of developing glaucoma after blunt trauma is 3.39%. After penetrating injury, it is 2.67%. Glaucoma after blunt trauma appears to have two peaks of incidence. First can be immediate or within 1 year after trauma, and second can be in between 1 to 10 years after trauma. Early onset glaucoma can be due to trabecular meshwork damage, trabecular meshwork dysfunction, mechanical blockage of the TM, or ghost cell glaucoma or hemolytic glaucoma also. And late onset glaucoma can be angle recession, secondary angle closure because of the peripheral anterior synecdoche, sudden closure of the cyclodialysis cleft, epithelial downgrowth, retained intraocular foreign body, and even because of the rhegmatogenous retinal detachment because of the pigment release from the RPE. So early onset glaucoma, patient is aware of the trauma, he is symptomatic, and various ocular signs can be identified. But in late onset glaucoma, patient is unaware of the trauma. He is unaware of the chronically elevated intraocular pressure, and sometimes there can be absence of signs of trauma. So it is important to identify eyes at risk for chronic traumatic glaucoma, to monitor them and to treat them as early as possible. So what are the predictors of late onset glaucoma? This can be initial high intraocular pressure, 22 to 60 millimeters of mercury. There can be presence of hyphema. Heavy trabecular pigmentation grade 3 is a significant predictor for late onset glaucoma. This causes obstruction of the trabecular meshwork, and even the endothelial cells phagocytize the pigment particles and they block the trabecular meshwork. The next predictor is angle recession, injury to the lens, and inflammation. So what is physiology of the secondary glaucoma secondary to blunt trauma? So there can be mechanical disruption following globe trauma. Usually in fresh trauma, gonioscopy has to be avoided, it's not recommended, but later on you can see superficial tears of the trabecular meshwork as flaps, or full thickness tears also can be seen with torn iris processes or blood in the angle. So these are the indicators that there is a trabecular meshwork injury. So next is inflammation. This can be because of the iritis or trabeculitis, and they compromise the blood aqueous barrier. They block there is leakage of the protein and increased resistance of the TM, leading to rise in intraocular pressure. Inflammation of the TM leads to decrease in the aqueous flow gain. So next is obstruction of the TM because of the hyphema. So this can be blocked because of the erythrocytes, fibrin, platelets, and other byproducts of the fibrinolysis, and this may lead to prolonged increase in the intraocular pressure. Source of the hyphema is tearing of the blood vessels because of the sudden trauma, which leads to the anterior posterior compression, and this sudden rise gives rise to damage to the fragile blood vessels of the iris and ciliary body, and this can cause hyphema. So hyphema can be seen like this inferiorly usually, and even on AIOCT you can see hyphema here in the inferior angle. So next is obstruction of the trabecular meshwork because of the lens particles. Again, a young girl, patient had blunt trauma with a tree branch. You can see there is a rupture of the anterior capsule and the pressure is gone up. So you need to manage this surgically by removing the cataractous lens and also treating the raised intraocular pressure. So there can be acute increase in intraocular pressure following severe eye trauma because of the choroidal hemorrhage, and there is a mass effect in the posterior segment which causes forward displacement of the lens iris diaphragm, and this leads to secondary angle closure glaucoma. Ghost cell glaucoma is seen within 1 to 3 weeks. There are RBCs which change their shape, consistency, they become spherical and rigid, and they contain Heinz bodies which is called as ghost cells, and because they are rigid and non-flexible, they block the trabecular meshwork. Those ghost cells are definitely not formed in hyphema. This is because of the rapid circulation of the aqueous humor and due to high oxygen pressure in the anterior chamber. So intermediate and late onset glaucoma can be due to trabecular meshwork and ciliary body damage. So there is an inflammatory response initially which clogs the trabecular meshwork, and there is damage to the which leads to late onset rise in pressure. Again, the reparative process in ciliary body and trabecular meshwork is damaging because of the fibroblastic response. There is scarring and trabecular meshwork damage. So this can give rise to raised IOP in later on. Ghost cell glaucoma again can be. Oh, sorry, I pressed the wrong slide. So hemolytic glaucoma we know is a rare, and this is because of the hemolysis of the RBCs from the vitreous hemorrhage, and the released debris they obstruct the trabecular meshwork, but here also there are no ghost cells seen in the trabecular meshwork. So next is lens dislocation or subluxation. So there is anterior dislocation of the lens which leads to pupillary block. Even the posterior subluxation can give rise to vitreous prolapse which can lead to pupillary block due to vitreous and raised intraocular pressure. Sometimes there can be intermittent closure because of the dislocated lens, and again there can be inflammation because of the dislocated lens, so which may give rise to raised pressure. Important is cyclodialysis cleft because this cleft gives rise to low pressure initially, but if it closes spontaneously, IOP may increase, which we have to remember even if there is a low pressure initially. So the most important late onset glaucoma is angle recession. This is defined as a tear between the longitudinal and circular layers of the ciliary muscles. This is usually seen in the superior temporal quadrant. There is asymmetry in the gonioscopy findings in different quadrants also, and in the right and left eye. Widened ciliary body band is seen, there is excessive pigmentation and deepened AC in the same quadrant. So there is a trabecular dysfunction and decreased outflow because of the damage to the ciliary muscles. So angle recession glaucoma after blunt trauma is seen in 20% to 90% of patients. If there is a presence of hyphema, this can be goes as high as 71% to 100%. So angle recession glaucoma in presence of angle recession is 1 to 20%, and this depends upon the extent of the angle recession. If it is more than 180 degree, the percentage is 4 to 9, but if it's more than 240 degrees, the percentage goes very high. So this is a patient of blunt trauma, and you can see the angle recession in various quadrants, especially in the temporal as well as the inferior quadrants, and there are torn iris processes also. So angle recession sometimes can be missed, and you need to really look for it. You can see like a indentation gonioscopy, the way we do in a narrow angle, you can indent a patient, ask the patient to look in the direction and see that widened ciliary bond is there, which is because of the angle recession. So trauma due to secondary penetrating injury is also there, and this may lead to shallowing of the anterior chamber, extensive AC formation of the anterior synecdoche, inflammation, Posterior synechium also can be there, which may lead to seclusion of the pupil and iris bombae, leading to closure of the angle. So traumatic glaucoma due to penetrating injury can be because of the injury to the lens, mechanical obstruction of the TM, hydration of the lens, which increases the anterior posterior dimension of the lens, leading to iris bowing and ankle closure. Also, there can be retained foreign body, as seen here. There is a retained glass foreign body which may rise to low grade inflammation and raised intraocular pressure later on. So medical management consists of reduction of intraocular pressure with aqueous suppressants and also control of inflammation with the help of cycloplegics and steroids. So reduction in IOP is the mainstay of treatment. So we have to have stepwise approach, like medical management first, lasers and surgical management. So most important, we need to avoid pilocarpine in patients with angle recession because it may cause paradoxical elevation of intraocular pressure, and hyphema can cause rebleeding. So to be given very cautiously. You need to avoid prostaglandins and prostaglandin analogs in patients again with hyphema and with patients with inflammation. Lasers, coming to lasers, so laser iridotomy is indicated if there is a pupillary block because of various reasons. SLT and ALT is relatively contraindicated because you are directly treating the trabecular measure which is already damaged. So this can give rise to further scarring of the angle structures, and there is a risk of IOP spikes. TSCPC reduces aqueous humor formation, and hence it is useful when you cannot do surgery because of the corneal or conjunctival problems. YAG goniopuncture also has been tried. So surgical intervention indication is that maximum medical treatment is not effective to control IOP, and there is optic nerve damage which is imminent. So timing and nature of surgical procedure has to be decided by nature of the injury, degree of the intraocular pressure elevation, conjunctival health of the patient, presence of inflammation and concomitant ocular comorbidities. So early intervention is needed if there is 8-ball hyphema, if there is corneal blood staining, or if there is a rebleed. Trabeculectomy of MMC has a better control. Even tube shunts with AGV are tried if there is a conjunctival scarring. Other surgeries can be indicated whenever needed, like lensectomy, vitrectomy, or you can do combined surgeries also. So this is an anterior chamber AGV which we had done in a patient with disfigured eye, and this is a pars plana AGV where you can see there was occlusio pupillae with very shallowing of the anterior chamber and posterior anterior synechiae also. So thank you for your patient hearing, and I have to run for another IC. So if there are any questions, I would like to take immediately. Thank you.
Thank you, Dr. Prabhudesai, for extensively covering on a vast topic.